Often when we hear the term facial plastic surgery, we generally think of a procedure that is often sought to help eliminate the facial signs of aging, maybe looking younger, feeling better about oneself. Well, actually, this is only one aspect of this kind of surgery. In addition, plastic surgery is beneficial in helping people return to a more normal lifestyle following accidents, other types of surgery, and even deformities developed as a result of having a stroke. It is a varied and it is an interesting field, and today on Research Report, we will explore the many faces of plastic surgery. Stay with us. My guest today on Research Report is Dr. Philip Miller. He is a plastic surgeon and he's an assistant professor in the Department of Otolaryngology at New York University School of Medicine. And if I understand it correctly, your specialty is dealing with surgery that is performed above the neck.
That's right, facial plastic surgery.
One of the more common things that occurs in people, and that has been not really resolved for a long period of time, is the frozen face that happens when something goes neurologically wrong. You've developed in that area a number of techniques with your cohorts. Tell us a little about what you're doing.
Sure. Individuals who have sustained facial paralysis or the inability to move a portion of their face as a result of trauma or infection or after undergoing tumor resections from the brain frequently have left a face that doesn't move, or even worse, at rest, is quite asymmetric from the other side. Recognizing the need for rehabilitation in that area, we have been doing research and work on rebuilding the facial structures.
Well, what is it that you do? Do you repair the muscles or the nerves or the bones? What exactly do you do?
Often the muscles remain intact. It's the nerve going to the muscles that have been damaged in one way. The nerve carries electricity, if you will, from the brain to these muscles, and it's the electricity that doesn't seem to be getting to those muscles. Now, the face, let me show you here, Frank. The face has a variety of muscles, and they work in concert in a very complex manner in order to give facial expression. You contract the muscles around your eye and on the top of your brow to close your eyes. You raise the frontalis muscles to raise up your eyebrows. You contract a whole host of muscles in order to snarl. You use even less to smile. This is the rosaurus muscle and the one around your mouth. And then several more muscles in order to grin or to pucker your lips. So the muscles here in facial paralysis are often intact. They're working okay. The problem is electricity from the brain is not getting to those muscles.
Is that what happens in Bell's palsy and other nerve damages and so on?
Now, that's a great question. We should make a distinction. Bell's palsy is often used by the public to describe facial paralysis. But in the medical field, Bell's palsy takes on a specific diagnosis. When you have facial paralysis, as I mentioned, it's due to trauma or infection or a variety of other insults to the nerve. But when we can't find a reason, when we can't find a tumor, when we can't find an injury, then that term we use to describe the paralysis is Bell's palsy. In the last several years, we've identified that that is actually an infection, a viral infection, which causes what we used to think was facial nerve paralysis of unknown cause.
So what you have to do then is you're not going to fix the muscles. They're okay. You're going to fix the nerves.
We're going to go after the
nerves. How do you find which nerve? I mean, what do you do?
Well, what we've seen is that the nerve going to the facial muscles remains intact. It's there. But again, the electricity isn't going through the nerve to the muscles. And unfortunately, we can't get the brain to send electricity through that nerve to the muscles from its original connection. So we have to use another nerve, a nerve that's working in the face, and hook up that nerve to the facial nerve. And let me show you here which one we use. This is a diagram of the facial nerve as it comes out of the skull, and it goes into the face and innervates or touches the muscles of facial expression. Now, we know that this nerve, while it's intact, while the fibers are still here, unfortunately, electricity from the brain is not able to go through this nerve. So we use this nerve here, called the hypoglossal nerve, or the nerve going to the tongue. We use this intact nerve as a means to get electricity from here up into the facial nerve. Now, there are a variety of techniques that can be used to do that. The first one was simply to cut the hypoglossal nerve, the tongue nerve, cut the facial nerve, and then you actually swing the two together. The problem with that, as we can see, is that the nerve going to the tongue has been interrupted. Mm-hmm. So the tongue gets paralyzed. Furthermore, this is a very, very hardy nerve with lots of energy. So by connecting the two together, you're sort of putting, if you will, a 240-volt connection to 120-volt. And the face can get very, it can become spasmed and be almost too interactive. So another idea was developed, and that idea was to not use the entire nerve, but just use a portion of the nerve. And if you splice just 50% or 40% of the nerve, keep at least 50 to 60% going to the tongue, and then take a graft from somewhere else in the body, and you could connect just 40 or 50% of these nerves up into the facial nerve. And that gave an even better result while not sacrificing the tongue. However, it was two connections, so there were two potential points of failure, and the nerve taken here as the jump graft, as we call it, clearly resulted in a defect or a deficiency in another part of the body. So looking at this, we thought of a new technique. We said, well, why don't we just take the nerve from the skull and attach it here to the nerve going to the muscle of the tongue. And while it looks like it can be done quite simply here in this diagram, in reality, it's not so simple. This is just too short. Interestingly, the facial nerve, however, travels in a circuitous fashion within the bone before it gets to the brain. So we said, hey, why don't we actually just let's drill out the bone and unroof the bone and just peel the nerve out of the bone, which would give us enough length, and then attach it to the nerve down here going to the tongue. And that way we would only have one connection, and we wouldn't have to sacrifice a nerve elsewhere in the body. And that's depicted right here, taking the facial nerve from its connection to the brain and connecting it down here.
That would involve quite a bit of surgery, wouldn't it?
It does. Dr. Thomas Rowland, who was the originator of this technique, is my associate and is a skull-based surgeon at New York University School of Medicine, and he does a fabulous job with dissecting this nerve from where it exits out of this temporal bone all the way up towards the brain, carefully dissects it out of its canal and peels it out in a really spectacular fashion.
This must be done through what? Through microscopes? I mean, you're dealing with a tiny area right in there.
That's correct. It's extraordinarily, painstakingly meticulous work because we don't want to injure the nerve. We have to pull it out and keep it preserved in its normal, healthy state. And so we use microscopes and instruments that are extraordinarily small. And when we sew these connections together, we're using sutures that are smaller than the width of a hair.
What kind of patients would you use this surgery on? I mean, what types of problems would you use?
Most frequently, we use this in individuals who have had brain tumors, particularly acoustic neuromas, which are often benign tumors that sit right next to the nerve, the facial nerve, right next to the nerve responsible for the animation of the face. And in removing that tumor, unfortunately, the facial nerve can get injured. Frequently, when it happens, the nerve comes back by itself. Unfortunately, there are occasions when the nerve is permanently damaged.
Would you use this in stroke? In other forms of neurological problems?
Stroke, it can, but we have not used it in stroke patients, and often stroke patients recover quite well on their own, or they have damaged a variety of nerves, making this particular reconstructive effort less likely.
Now, you have some pictures of the surgery, which is, I just want to tell the audience,
Yes.
we're going to show some pictures of the surgery. So run us through that quickly.
My
Tell us
pleasure.
what it is.
It is quite graphic. The first thing we're going to see is, this again is viewed through a microscope. The front of the head is here, the back is here, the feet are down here, and the top of the head. But of course, this is focused quite closely to the head. And this is the bone right behind an individual's ear called the mastoid that has been already operated on and removed. And we see in this white pattern right here, that's the facial nerve as it courses from outside of the skull in towards the brain. Mm-hmm. The first thing that we'll do is very carefully take the bone off of this nerve. Dr. Rowland does this in a spectacular way, and peels the nerve out of the bone. This is the nerve laying in its original position, and we take that and flip it down into the neck where we're going to connect it to the nerve that goes towards the tongue.
This kind of surgery takes how long?
Anywhere from 2 to 4.5 hours.
And what is the success rate on this kind of surgery?
We're getting quite good at getting at least symmetry at rest, because there are two different types of paralysis. There's the paralysis where an individual is unable to smile symmetrically or close their eyes, and then there's the paralysis where at rest the individual is looking at you and one side is drooping. So to get the second, if you will, to get the second paralysis fixed, getting symmetry at rest, we've gotten very good results. In reanimation and getting the face to actually work in symmetry, we've had also pretty good success.
Okay, we're going to take a break now. We'll come back, and you have some examples
Sure
of patients before and after, and we'd like to see that. So stay with us, and we'll be right back. We've very often seen people who have a frozen face, partly frozen or entirely frozen, and with surgery that can be corrected, and we're discussing some of the surgery. You brought some samples of what happens when you lose that ability to function, the muscles to function anatomically.
Mm-hmm. We can see here on the left side of the screen the rather typical findings of a patient with facial paralysis. A brow that is lower than the unaffected side, the lower lid, which is drooping compared to the unaffected side, the right cheek, which falls, and the corners of the mouth, which fall. Now, these problems can occur at rest, but are accentuated when an individual smiles. With not only doing the nerve repairs that we saw, but doing other work on the eye, as I'll get into, I hope, in a few moments, we can give a result 9 months after the surgery, which returns somewhat symmetry to the face of an individual who has had an acoustic neuroma resected and sustained facial paralysis from that surgery.
And the next?
Yes, thank you. These are the findings that, again, you see after facial paralysis. The lower lid is pulled down, and the inability of the eye to close. Contrary to what we might think intuitively, the facial nerve, the nerve responsible for the animation of the face, closes the lid. It doesn't open it. So when the nerve is paralyzed, we're unable to close our lid. Using a variety of techniques that I'll get into in just a moment, we're able to close the lid better, and we're able to also bring up the lower lid so that there's not as much what's called scleral show. This can actually be quite a devastating side effect to facial paralysis, because with exposure of the eye like this, you can get dry eye syndrome, you can get ulcers, and in very rare cases, but severe cases, blindness. The way we treat the upper lid, this is a cross-section of the upper lid. Here's a little bit of the lower lid. What we do is make a little incision and then place right in front of the upper lid a gold weight. And what the gold weight does is actually weighs down the upper lid so that at rest the eye falls down, and when we try to open the eye, we are able to contract the muscle that still works and bring the lid up. And then when we relax the eye, it falls back down again. I have a gold weight here if you want to just take a look at it. That's a 1.2 gram gold weight. It really is gold.
That isn't very heavy. It's extremely light. And that's enough to get the lid to actually pop right down?
That's right. The weight comes from 0.8 grams all the way up to 1.8 grams, and we measure the weights on on individual's eye right before the surgery to determine which one we should use.
So what you're doing is more than just neurological compensation. You're doing structural changes.
We're doing
too.
structural changes.
All right.
Okay. We have photographs of the procedure itself. Again, these are somewhat graphic for the audience, so be mindful. An incision is made in the upper lid, and some tissue is removed. And here's the gold weight inserted right where we want it to go. We suture these in place, and then we'll go ahead and close the lid. Often, we'll take a little bit of the skin of the upper lid, which is redundant in these individuals as well. We'll do a little bit of a cosmetic blepharoplasty, as the term is used, as well, which helps restore symmetry to the face. And then we close it here. This is just a protective shield on top of the eye. The other maneuver that we use to repair the lower lid, which has become lax because there's no structural integrity from the muscle tone loss, is to find the supporting structure called the tarsus, which runs across the lower lid, and we take that and pull it up in order to tighten the lower lid. That's called a tarsal strip or a tarsal canthoplasty. And again, here is the before and here are the afters, so we can see that we've tightened the lower lid using that tarsal strip procedure, and by placing a gold weight and doing a very modified blepharoplasty technique, we can actually allow the lids to close.
Now, is the repair, the nerve repair that you showed us before, that main nerve, are there other nerves that may be involved in your surgery too when you're doing this?
We typically go after those two nerves, the facial nerve, which obviously is the nerve that is injured, and the hypoglossal nerve, the nerve to the tongue, because it provides such good bulk. Others in the country are investigating other nerves, such as a branch of the trigeminal nerve, another nerve that runs in the face, to use that as the conduit or the route for getting electricity from the brain into the facial nerve. So other nerves are being explored.
Most people, when they think of plastic surgery, think of, as I mentioned in our introduction, beautifying one, changing the structure of the nose, the cheeks, adding material to bring out a chin, and so on and so forth. Yours is reparation, repairing structural defects and repairing nerve defects. Are there major problems with rhinoplasties, nose jobs, as they call it, because this has become a great institution in our nation?
Right. Well, I think you bring out quite clearly that form and function are closely related, and while we can repair the function, we have to keep in mind the cosmetic or the aesthetic ramifications, and likewise, when we perform aesthetic procedures, we can't forget that we're interacting in some respects on the functional aspects.
So what could go wrong? I mean, if I come in and I get a brand new nose and I'm younger by 10 years or so, what can go wrong?
Unfortunately, besides not being satisfied with the way the nose looks, unfortunately we can interrupt the function of the nose. And quite commonly, particularly 20 years ago, pretty noses were coming out, but non-functioning noses were coming out.
Can you show us what happened?
Sure, sure. I think for the audience's sake, we might want to explore a little bit of the anatomy so that we can better understand the nasal structures and understand why this is such a complicated operation.
Take us through it.
Okay, this is obviously a skull, but we're going to concentrate just on the nose itself. And as we've seen in our high school biology classes, we know that the nose from a skeleton really doesn't look like a nose at all. There's a little bit of nasal bone up here, but from the side view you can see that almost no nose exists on the skeleton itself. We have to add to the bone. And what we're adding is cartilage. Cartilage is like celery. It can bend, but ultimately can break, and it's what our ears are made of. That's what cartilage is. The first piece of cartilage we've added to the skeleton is the septum, which is the partition between the right and the left nostril, separating the chambers. Now, we've often heard of the term deviated nasal septum.
Everybody's got it.
Everybody's got one of those. And what that means, and this skeleton has it as well, is that the septum, rather than being perfectly midline, is shifted off to one side or the other, or buckled, or fractured to a certain degree. But that's what we refer to as a deviated nasal septum. But But even this doesn't look exactly like a nose. We have to add another structure. And what we're adding now is the upper lateral cartilages. And those extend off of the nasal bone and come down to the top portion of the nasal septum, and that creates the mid-third of the nose. We can get an idea of what this contributes to our nasal anatomy by pushing down on the tip of our nose. And when we do that, we see the nasal bones and the upper lateral cartilages, as we can see in this patient example. But still, we haven't built the tip of the nose. We have to add yet a third piece of cartilaginous structure. Besides the nasal septum, besides the upper lateral cartilage, we have to add now the lower lateral cartilage. And that is a freestanding structure that comes up above the nasal dorsum, or the nasal bridge, and that is what constitutes, or what creates, the nasal tip. We can see the tip of the nose and the bridge of the nose, and this looks more like what the nose typically looks like. Here it is again on the right side. There obviously would be a paired lower lateral cartilage on this side, and then if we add skin on top of all of this, we get, if you will, a nose. Now, some of the problems that occur in rhinoplasty in an effort to make a pretty-looking nose is to remove some of that cartilage, or remove too much of that cartilage.
The structure.
The structure, the very structure that builds our nose, we can take too much of it out. And in the process, we lose that support, the structure necessary for us to breathe. This is a case in point. This individual had 2 rhinoplasties already, not because she wasn't satisfied with the look of her nose, but because she couldn't breathe. When she tries to take a deep breath, the nose pinches in because it's lost all of that structural support on the side of the nose. Here she is in her relaxed state, and when she breathes in, she collapses on both sides. And why is that? Well, you know that this portion is bone,
right,
and we've just seen that this portion here is the upper lateral cartilage.
And that's collapsed.
And you can see that this is collapsed. There's a step off from here to here. This whole area is collapsed. So while we try to maintain post-operatively the look of her nose, we're also trying to rebuild the structural integrity of this area so that when she breathes in, it remains open and wide, and you have not only form, but function. Let's go over another problem that can occur in rhinoplasty is this individual had a rhinoplasty and afterwards was unable to breathe. He also had collapse in this region here called the external valve. That's an area where the bone and the lower lateral cartilage connect, and if it's weakened, it just collapses in. But the prior surgeon also tried to address this area by putting a piece of cartilage in, which somehow migrated up to the tip of his nose and gave him this extra bump. And that, unfortunately, cannot be another consequence of cosmetic surgery, is where you put things sometimes move. And we try to carefully put them into what I call perfect pockets, or suture secure them with our sutures, our threads, but occasionally they don't stay there. So in this individual, we not only removed the cartilage, the cartilage that was placed in the wrong position, but we also projected the tip of his nose, and we also tried to bring it down a little bit, because both of those maneuvers, both of those states gave him a rather sort of short, snub-like nose, and he wanted it further out and slightly counter-rotated is the term. In order to do this technique, we needed rib cartilage. And it brings out another interesting distinction between primary rhinoplasty and the complex revision rhinoplasty. Revision rhinoplasty often requires that we use a variety of other material, different tools, different techniques than primary rhinoplasty. Whereas the primary, we're often taking things out. In the secondary, we're
putting it back,
adding it in.
Yeah.
We can take cartilage from the septum, or the partition between the right and the left nostril. If there isn't enough there, we often go to the ear. We can take a fair amount of cartilage from the ear without distorting the way the ear looks. Another possibility is taking it from an individual's own rib. And if those three aren't appealing to the individual, or we can't take it for one reason or another, we use artificial material, some of which I brought with me today. This is actually SAM, or subcutaneous augmentation material. The real term for that is Gore-Tex. Believe it or not, it's medical-grade Gore-Tex used for facial plastic surgery.
And this is for revision, or is it used in primary?
It can be used in either for the fewer cases of primary that require augmentation or addition of tissue. We can use this material, but often in primary there's enough cartilage or tissue elsewhere in the body that we can use. It's often in the revision rhinoplasty case where there isn't enough tissue. The ears have been already operated on. The nose has been already operated on. That we must resort to these materials. Another one is this one, as you can feel, is rather soft and malleable.
Yes. Mm-hmm.
This is another material called MedPore, and what that is, that actually is quite structurally sound, and it gives us the definition and the support that is so much lacking in revision rhinoplasty.
You don't hear much about revision. Why? You hear or you see changes in an individual, and you know they've had some kind of surgery, but you don't hear much about revision. What are we talking about in time frame? When somebody like that, or the woman before where the structural integrity was affected and the nose collapses, how long does that take?
It can take anywhere from a year to almost 10 or 15 years. It really and demonstrates why rhinoplasty is such a complex operation. We're not only dealing with the structures that are there at the time of the surgery, but also the healing process, the way the nose contracts over time. The skin in an individual has to be taken into consideration because thicker skin contracts less and thinner skin contracts more. And so that has to be another component taken into consideration when evaluating the steps necessary to correct an individual's nose. So it can be varied. It can be quite in the first year. It can be later. But I think one of the main reasons we don't hear about it so much is the public may not necessarily be familiar with the distinction between a revision work and a primary work. They are botching it all together, if you will, as another nose job. But it really is two quite different surgeries.
Well, Dr. Miller, you've taught us a great deal about plastic surgery. It's more than just a pretty face. It's you said form and function, and at one point, I guess, form was the most important thing. I have to come out of this with a nose that will get me on to the soap operas or whatever, and function was not so important, but today we're beginning to think more of function. And I thank you so much for joining us here today and telling us about your work. Thank you for joining us. And thank you for joining us today on Research Report.